second. Okay, fine. Right. We need clarity about fee terminologies, and I think this is a misconception that people have, and we need to be absolutely certain what we are talking about. BPH, remember, is a histological diagnosis. It is not something that you make clinical. So there could be a clinical BPH, but it's predominantly histological diagnosis. BPE stands for benign prostatic enlargement. Now, enlargement can be associated with obstruction, or it may not be associated with obstruction. The third terminology which is commonly used is BPO, and BPO stands for benign prostatic obstruction, and this obstruction is urodynamically proven. So that's an important point, and one should remember that. Essentially, when patient presents to you, he or she presents with lower urinary tract symptoms. So I said she because women also have lower urinary tract symptoms, but they don't have prostate. So if they have lower urinary tract symptoms, very similar to the urinary tract symptoms that men have, then it means that men can also have lower urinary tract symptoms without prostate. I think that's an important point to understand. So it's just not BPH, which is one entity, but there are a lot of various clinical conditions which can result in lower urinary tract symptoms, which are similar to BPH. So which could be detrusor related, which may not be related to lower urinary tract or even upper urinary tract. So remember that, that's an important point. Now, what about lower urinary tract symptoms in aging men? And I think this is what the topic is today. So it is presumed to be due to BPH or BPE or BPO. And I will explain further. These three clinical entities are quite different from each other. They merge at a certain point, but they're also in different entities. We know that BPH or BPH-like symptoms are increasing with age. So they are seen starting from the late 40s up to 90, and it keeps on increasing with time. Although it's sometimes difficult to link the exact etiology of these symptoms with prostate. Another important thing to remember is that lower urinary tract symptoms could also be due to bladder, which means that if you have overactive bladder, or if you have bladder detrusor underactivity, which could be due to neurogenic or non-neurological causes, it can also produce symptoms very similar to BPH. One of the common symptoms that your patient often present with is nocturia, which means that they have to get up in the night quite a few times. And these are the symptoms probably not associated with BPH, but they are associated with what is called nocturnal polyuria. And we'll also touch upon that a little later. Now consider this circle to be all men who are above 50 years of age. So for example, in Pakistan, the population is 220 million. So presume that half of them are men. So there are 110 million men in Pakistan. Of these 110 million men, if even 10 million are above the age of 50 years, so this cohort basically represents 10 million people in Pakistan. A significant proportion of men above 50 years of age have histological BPH. So you start doing a biopsy of anyone who is 50 years of age, you will find BPH. But very smaller proportion of these men have low urinary tract symptoms suggestive of clinical BPH. There are some other audios also open. Can you turn off the audios so that there is no disturbance? Some of the participants have their audio on. Can they turn it off, please? Right. So these lower urinary tract symptoms. So what you see here is that histological BPH does not always mean that the patient would have clinical BPH as well. Now, of this proportion, men who have lower urinary tract symptoms, a smaller proportion have clinically defined or urodynamically defined obstruction called bladder outlet obstruction. And this bladder outlet obstruction could be due to an enlargement of the prostate. But important thing to see that people who have an enlargement of the prostate may not have low urinary tract symptoms. They may have clinical BPH only. So when the patient comes to you in the clinic and he puts an ultrasound report in front of you which says that the prostate is enlarged, it means nothing. And that report should be put aside, and you take a good history and make sure that what are you going to treat is really clinical bladder outlet obstruction or BPO. And what are the symptoms? We all know that the symptoms are poor urinary stream, urgency, difficulty in starting and maintaining a stream. You may be going frequently to the washroom. You're not emptying your bladder completely. And it becomes difficult to start and stop a stream. So all these are typical symptoms of BPH. This is the European Association of Urology's algorithm for evaluation of men who are in the age of BPH, which is now defined at 40, 45 years. Typically, it is 50 years plus. So these men should always have first history, and that history should also focus on sexual functions, because sexual functions are related to the treatment and management of BPH. So men who have preserved sexual functions may be treated in one way, and those who are not sexually active may be treated another way. It's important to objectively quantify their symptoms because they may have intermediate or low risk symptoms, whereas your definition of mild symptoms may be different from others. So if you put an IPS as a score and fill it up, it will give you an objective criteria. Urinalysis should always be done for these patients. Physical examination is important. PSA is not needed in every patient. PSA is only needed if you have a suspicious DRE or if the patient wants to have it, because he should understand that the PSA test may start off various investigations which may become a problem. So when the PSA be done, if you have an abnormal DRE, if you have an abnormal DRE, then you would have to do PSA. Neurological diseases can also be picked up on rectal examination. So rectal examination is important. Right? Post-void residual volume is more important than getting a transrectal ultrasound or this ultrasound or that ultrasound. The important question to ask from an ultrasound is that if the creatinine is raised, you need to know what are the kidneys like. If the creatinine is normal, urinalysis is normal, you don't really need to worry about kidneys. But what you need to really worry about is the post-void residue. So if you're leaving a significant amount of urine behind, this is an important observation, and it will be used in the evaluation of patients and making the treatment algorithm. So these are the EAU guidelines. So the most important lesson from this algorithm is a history, physical examination, and some very basic tests like urinalysis, flow test, and post-void residue are important. But this is the most important test. And if you don't do this test, and there are two things that majority do not do, even urologists often missed out, is a rectal examination and examination of the inguinoscrotal region. Now, if you do a rectal examination, you can pick up prostate cancer, You can have a fair assessment of the size of the prostate. You can assess the tone of the anal sphincter, which will indicate whether the patient has got an element of neurogenic issues. I have seen patients being on alpha blocker for months and years without any significant improvement, and nobody has examined them, and what they have is a meatal stenosis. So if you have a very narrow meatus, you will have symptoms very similar to BPH, but you don't really have BPH, and you would not be treated by alpha blockers. Uroflowmetry is a very vital test in defining obstruction, because if you do not have obstruction, just spinal jerk reflex, you start them on alpha blocker or 5-alpha reductase inhibitors, etc., will not work. You need to define if there is an obstruction, and which is done by uroflowmetry, which is a very simple test in which the patient is asked to pee, and various flow patterns would indicate what kind of problems the patient may have. And this include various curve types that would define various types. So this is the typical curve of a patient with BPH, and in which there is fairly good stream in the beginning, and then the stream keeps going down with time. And this is typical of a prostatic curve or a prostatic. This is an ultrasound, and you can understand the anatomy, that why prostate causes bladder outlet obstruction. So this is a urinary bladder. The urethra is passing through the prostate. This is the lateral lobes of the prostate. The urethra is passing through it. And when the prostate gland increases in size, the urethra is compressed. And as a consequence, what happens that the flow becomes poorer. This is another ultrasound showing significant protrusion of the prostate. So this black or hypoechoic thing is bladder, whereas this gray area is the prostate. And this prostate has grown into the bladder. And this is typically large lateral lobes. You can also have a median lobe like this. So this is a median lobe going into the bladder, where these two large lateral lobes are infiltrating into the bladder, causing bladder outlet obstruction. Sometimes you can assess the level of obstruction by determining how much the prostate has gone into the bladder. And this is called the intravesical protrusion of the prostate. So on an ultrasound, if you draw a line from the bladder to the other end of the bladder and see what is the length of the prostate in going into the bladder, and as a consequence, you can grade them into low-grade obstruction, moderate obstruction, or severe obstruction. So most men with grade 3 obstruction or grade 3 protrusion of the prostate will not respond to medical treatment. So you can give them 5-alpha or alpha-adrenergic blockers, they would not respond, and they would invariably require surgery. Okay, so urodynamic evaluation, which is invasive urodynamics, is only indicated in very select group of patients, and it is really for a urologist to assess whether these patients require urodynamic evaluation. And in essence, urodynamics is to differentiate between patients who've got neurogenic bladder and those who have got obstruction. And the one who have got obstruction will be treated with surgery, whereas neurogenic bladder would require treatment to some other means. So what is the pathophysiology, and why BPH results in bladder dysfunction? And this is the pathophysiological explanation very nicely provided by these authors, that BPH with bladder outlet obstruction resulting in high resistance to flow and high intravesical pressure results in detrusor hypertrophy and collagen deposition between the detrusor fibers. So what is happening is that you are pushing against resistance. And when you push against resistance, what will happen? That the muscles become stronger. So if you start exercising, your biceps will become stronger. So similarly, when the bladder has to work against a lot of resistance at the outlet, then your muscles would become stronger, and this is called detrusor hypertrophy. With detrusor hypertrophy, the in between spaces between the detrusor is filled with collagen. This results in decreased blood flow to the detrusor muscle, and as a consequence of this, there would be activation of the hypoxia inducible factor, which starts a cascade of events which ultimately results in bladder dysfunction secondary to BPH. Now, I've mentioned earlier on about the nocturia. Now, as you know that majority of patients who've got BPH often present with only nocturia, and sometimes it is the most bothersome symptom, that they have to wake up in the night, and as a consequence, their sleep is disturbed, and they are unable to, and their quality of life is disturbed. But remember that nocturia is not always due to BPH. If you have decreased bladder capacity for some reason, if you're taking a lot of fluids, particularly in the night, or if you are diuresing a lot in the night, all this can result in nocturia, and none of these are related to BPH. So this is an important slide, and you need to take a good history to make sure that you don't miss out on some of these other things which can cause nocturia. Remember that men with congestive cardiac failure have a lot of, and very elderly people have a lot of third spacing of fluid in the night and during the daytime while they are up and about, and all this fluid would be released into the systemic circulation, increasing the nighttime urine output. So it's actually nocturnal polyuria and not BPH related frequency. So again, how would you treat this? You obviously treat them by the cause. So if you have decreased bladder capacity, you would see whether the lifestyle changes, behavioral modification, ability to hold urine, decreasing the fluid intakes at night, and all these things may help. If it doesn't, if it is because of the diuresis in the night, you need to make sure that they don't have diabetes. Both diabetes insipidus and diabetes mellitus can result in nocturnal polyuria. And they can again be treated with either behavioral or lifestyle changes or with the use of various medications, anticholinergics, and sometimes the vasopressin analogs can also be used, and they are very effective. But remember that the vasopressin analog like desmopressin, which is also used for enuresis in children, can cause significant hyponatremia, and that can be extremely disastrous, particularly in the elderly patients. So you need to be mindful of use of desmopressin in that setup. Okay, let's skip that. So, right. Now, finally, we move on to the management, and we know that we have discussed a few things about the causes of low urinary tract symptoms, how to differentiate patients of low urinary tract symptoms from other causes of LUTS, which are not related to BPH. And once you have made a diagnosis of BPH LUTS, then you treat them. And you treat them, number one, and the goals of treatment is to decrease their symptoms. And you have an IPSS score to start off at the treatment, say of 18, and you try to bring it down to about 10 or under 10, and that would improve the quality of life. So this IPSS questionnaire became important. The validated Urdu version is available, and you can easily use them, a photocopy of that IPSS, and patients can fill it at various parts of their treatment to see if their symptoms are improving. So this is the most important point in management of BPH. You have to decrease their bother factor. The last question of IPSS is the quality of life question about how much bothered you are with this kind of symptoms. And you have to see that you have to bring down bother factor from 5 and 6 to 3 and 4. If the prostate size is large, and large means about 45, 50 and more, then it's important also to decrease the prostatic size in order to give long-term benefit to the patient. You also need to keep monitoring these patients who are on medical treatment to prevent long-term complications. And in the end, the important thing is that you should also be mindful of the fact that most of these agents which are used for the treatment of BPH are used for longer term period, and they have side effects. You need to monitor them for the side effects as well. Little bit about, before we start the pharmacological treatment, uh, let's just talk about a little bit about prostate itself. And prostate has a muscular component, fibromuscular component, and a glandular component. And it is this glandular component whose enlargement results in physical obstruction. And you can see the diagram here that this glandular component or adenoma of the prostate keep compressing on the urethra. And it is this glandular part which results in that kind of a physical obstruction, also called as static obstruction. Now, this fibromuscular component has a lot of alpha receptors, and the increasing tone of alpha receptors can also compress upon the prostate, resulting in shrinkage of or compression on the urethra, resulting in outlet obstruction. So what we have defined is that we have two kinds of obstruction in prostatic in patients with BPH. Number one is a dynamic obstruction due to the increased tone of alpha adrenergic receptors at the bladder neck and in the prostatic stroma. And this results in compression of the urethra. And this happens in all the patients with BPH. The other component, which is due to development of adenoma and static obstruction, is seen in a certain percentage of people, and it is generally considered that patients who have got prostate on ultrasound abdomen of more than 45-50 grams are the one who have significant static obstruction, and they require medication to take care of the static obstruction. So this obstruction and this obstruction are two different types of obstruction. This happens in all the patient. This happens in a smaller percentage of patient, and we need to treat both. If both are present, we need to treat one if only one is present. Okay, so these medical management of prostate of BPH is then focused upon two types of drugs. One is called the alpha adrenergic receptor antagonist or blockers, which predominantly work on the dynamic component of obstruction, as we have just talked about. 5-alpha reductase inhibitors like finasteride and dutasteride are the ones which work on an atomic obstruction or static obstruction. Remember, as I've shown you in the previous slide, that the cascade of events result in detrusor dysfunction over a period of time. And this is urodynamically called as obstructive detrusor instability. And this obstructive detrusor instability essentially results in a lot of bladder-related symptoms, which are due to which exhibit as voiding symptoms. So anticholinergic therapy is also required, and that's why you can see that most of the formulation available these days are either alpha blocker with 5-alpha or alpha blocker with anticholinergic therapies. Like anticholinergics are your detrusitol, tolterodine, or solifenacin, or oxybutynin, etc. Now, some of you who treat patients with hypertension know that the alpha receptors were initially introduced as antihypertensive drugs. And one of the classical non-selective alpha blocker was phenoxybenzamine, which is now not easily available, and it's only now used for treatment of patient with pheochromocytoma prior to surgery. Prazosin, which is Minipress, is still available, and it's also a non-selective alpha blocker. But both of these drugs have a lot of side effects, and these side effects are due to vascular side effects. And it is because that the vessels have alpha-1 receptors as well. And if you block them, there would be pooling of blood in the vessels, which results in orthostatic hypotension, meaning that when you get up, you become hypertensive because the vessels have pooled a lot of blood in it. So what has happened over the last 20 years that the industry and the research have developed alpha receptor which are selective for prostate. In prostate, we have predominantly alpha-1A receptors. And these alpha-1A receptors, the very typical examples of alpha-1A receptor selective receptors is tamsulosin and indoramine plus silodosin. And these are the typical alpha-1 receptors, alpha-1A receptor antagonist. So what we have is alfuzosin. Alfuzosin is not an alpha-1A receptor selective drug, but it is a functional selective drug. So research has shown that it predominantly works on the prostate, but it does not selectively block alpha-1A receptors, but somehow it works. So doxazosin, tamsulosin, and terazosin. Terazosin is Hytrin, which was again slightly selective alpha-1A receptor antagonist, but it has to have a dose titration. So you have to move from 1 to 2 to 5 to 10 milligrams in order to achieve. And it was a very commonly used, but not anymore. And so these are some of the newer agents. The indoramine is not really new, but neftodapil and silodosin. And I think silodosin is now available in Pakistan. This is the half-life, and that basically explains why most of these alpha blockers can be used as once daily dosage. So tamsulosin, MR, and OCAS have half-lives close to about 12 to 14 hours, and that's why they can be used as once daily dosage. Same is for alfuzosin, but alfuzosin, again, it has to be XL preparation for once daily doses. Otherwise, if you use 5 milligram alfuzosin SR, then it has to be twice a day. What are they? Any alpha blocker which is better than the other one? Meaning in terms of efficacy, the answer is no. So all alpha blockers are very similar in their efficacy. They reduce the IPSS score by 1/3. So if you have 18, you can have a score of close to 12 within 3 months. They increase the flow rate. So if you have a flow rate of say 10, it may increase to 12.5 or 13 with alpha blockers, and they work very quickly. So you have immediate impact within days. However, it does not work on prostate size. So the prostate size will stay the same. And the data has indicated that they do not really prevent long-term acute urinary retention episodes. And they typically work from few months to up to 4 years. So majority of these patients who have significant obstruction and they are on alpha blockers, they may require some form of surgical treatment later on. So what in terms of side effects? Well, asthenia or a generalized weakness, dizziness, and orthostatic hypotension, as we have talked about earlier, is seen with all alpha blockers, and alpha blockers are slightly different in terms of their receptor selectivity, and as such, their side effect profile is different, but their efficacy wise, they're all the same. Other side effect is also patients who are about to undergo cataract surgery should not have alpha blockers, because it makes the life of ophthalmologist very difficult. When they are doing a cataract surgery, the iris becomes unstable and becomes floppy, and that makes cataract surgery really difficult. So these patients should not have alpha blockers prior to cataract surgery, and this is called a floppy iris syndrome. Sexual dysfunction, libido and erections are not affected adversely by alpha blockers. Ejaculation is. And I've recently learned that one of the alpha blocker called alfuzosin essentially does less of ejaculatory dysfunction. So men who are concerned about their ejaculatory function or who want to have more children, then they should be given alfuzosin rather than tamsulosin, because tamsulosin is very effectively paralyzes the bladder neck and can result in retrograde ejaculation. Right, coming to the second class of drugs, which is 5-alpha reductase inhibitors. We have finasteride and dutasteride, and the difference really between the two class of drugs is not much. You can see that the acute urinary retention risk reduction is seen just over half of these patients. And the chances that they may require surgery, patients who are on 5-alpha reductase is really decreased to half in both the groups, slightly more for finasteride, slightly less for dutasteride. Their side effect profile is also not very different. Erectile dysfunction, decreased libido, ejaculatory disorder, gynecomastia, and so these are all an indication of testosterone blockage. So remember that patients who are young and who are sexually active, you should be very careful in prescribing finasteride and dutasteride, because both of these drugs can cause significant sexual dysfunction. What about combination treatment? Again, as I've said, that patients who've got large prostate have element of static and dynamic obstruction, and they should receive preferably the combination treatment. And the advantage of 5-alpha reductase inhibitor is that it can arrest disease progression. So these men would have really a decreased chances of acute urinary retention and decreased chances of need for surgery on a longer run if they are on combination treatment rather than if they are on single agent alpha receptor antagonist or alpha blockers. So for the sake of time, I'll just skip some of the slides. As I've said that the bladder dysfunction is also a common thing in, and it is not a silent observer. It really suffers because of the prostate. And these bladder symptoms are the most bothersome. It's important that these patients should be on anticholinergics, and those who cannot tolerate anticholinergics, you have beta-3 adrenoceptor and agonist, which includes mirabegron, and it's available in Pakistan now, mirabegron. So it has the typical side effects of anticholinergics like dry mouth, constipation, dry eyes are prevented by mirabegron. So what about surgery? When do men need surgery? Sorry, this is another, let me just, before surgery, this is one more thing we need to talk about, and this is the PDE5 inhibitors. They are not available officially in Pakistan. Maybe the companies can fight a case that they are used for lowering tract symptoms and BPH, and not just for erectile dysfunction, and the our drug authority may allow that. So the PDE5 inhibitors like tadalafil and sildenafil, typically studied is tadalafil, also helps in BPH, and they help in various mechanisms which are described here, which includes the increased vascularity of the prostate in that area, and all that, and some impact on the alpha afferent nerve activity. Intraprostatic inflammation is decreased, and this can result in help in So if you look at the guidelines, they have some impact on decreasing the IPSS and IEF scores. IEF score is the erectile dysfunction score, but not significantly the Qmax. So typical patients who require PDE5 inhibitors with BPH are younger men with low body mass index and more severe LUTS. They are the one who will benefit the most from the treatment of PDE5 inhibitors rather than alpha blockers or 5-alpha reductase inhibitors. So essentially, the message is that BPH incidence increases with age. Remember, not every man with low tract symptoms above 50 years of age has BPH. Quality of life and symptom improvement is the most important goal, and combination treatment have some benefits over single treatment. The question often is that how long are you going to keep treating this patient and when you're going to refer him to a hospital for surgical or interventional treatment. So if you have, as I've said early on, if you have a large intravesical protrusion of the prostate or large median lobe, as you see on ultrasound, these are the patients who would not respond to medical treatment, at least for long, so they should be referred early. Patients who've got complications secondary to BPH, like development of stones in the bladder, are again the one who would require treatment surgical rather than medical, so they have to be referred early. Patients who've got recurrent urinary tract infections, large residual urine and acute urinary obstructions and retentions, hematuria, are again the ones who would require treatment surgically rather than medically. So to conclude, the absolute indication for surgery in patients with BPH include refractory urinary retention. The refractory retention is defined as that you give them alpha blockers or 5-alpha reductase, and they have trial of catheter which fails. So this is refractory retention. Or patients who've got chronic retention with bladder outlet obstruction resulting in obstructive uropathy. They are also the ones who would require surgical rather than medical treatment. Those who have complications like recurrent urinary tract infections, hematuria, bladder diverticulum, chronic inflammation, bladder stones are again the one. What are the relative indications for surgery? I would say that patients who've got large, high scores like greater than 20 IPSS, who failed medical treatment, whose Qmax is under 10, or whose post-white residual volume is under 100. So these are the things that you need to, as general physicians, have to remember that this is the point where you would start thinking of referring these patients to a hospital and urology care rather than continue treating them with medical treatment, right? So thank you very much for your attention, and I'll be happy to take any questions that you may have.
Thank you very much, sir. Indeed, it was a very comprehensive talk on LUTS management. And if any doctor wants to ask question, you may please ask.
Assalamu alaikum. Assalamu alaikum.
जी वालेकुम सलाम.
जी आई एम डॉक्टर नईम. मैं हॉस्पिटल में होता हूँ और आई एम वर्किंग एज गैस्ट्रोएंटरोलॉजिस्ट. मेरा क्वेश्चन ये है कि पेशेंट में जिसमें यूरिटेरिक स्टोन हो, व्हाट इज द रोल ऑफ सच ड्रग्स इन यूरिटेरिक स्टोन्स?
ओके, जिनको यूरेटेरिक स्टोन होता है वो यूरेटर के अंदर भी अल्फा रिसेप्टर्स होते हैं. तो अगर आप अल्फा रिसेप्टर एंटागोनिस्ट लाइक अल्फा ब्लॉकर्स एंड टेम्सिलोसिन वगैरह इस्तेमाल करेंगे तो यूरेटर रिलैक्स हो जाता है. यूरेटर रिलैक्स होने की वजह से वहाँ से पत्थर के निकलने के चांसेस बेहतर हो जाते हैं. तो स्मॉल स्टोन्स अप टू 5-6 मिलीमीटर्स कैन पास विद मेडिकल ट्रीटमेंट. उसके अलावा दूसरी दवाइयाँ भी उसके अंदर इस्तेमाल हो सकती हैं, जैसे कि स्टेरॉइड्स हैं जो कि एडिमा कम करते हैं, कैल्शियम चैनल ब्लॉकर हैं. दे आर ऑल डॉक्यूमेंटेड, बट अल्फा रिसेप्टर्स जो हैं सबसे इफेक्टिव होते हैं. तो आप उनका पेन कंट्रोल करते हैं और उसके अलावा आप उनको अल्फा रिसेप्टर ब्लॉकर्स देते हैं. तो ऐसी सूरत में यूरेटेरिक स्टोन की मेडिकल मैनेजमेंट हो सकती है. इसको हम मेडिकल एक्सपल्सिव थेरेपी कहते हैं.
पेरिफेरल सेटअप में, आई मीन के क्लिनिकल सेटअप में, अगर हम कितनी देर के लिए पेशेंट को ये ट्रीटमेंट दे सकते हैं एज ए ट्रायल बिफोर रेफरिंग टू यूरोलॉजिस्ट?
बहुत अच्छा सवाल किया आपने। देखिए, जो यूरेटर की ऑब्स्ट्रक्शन है, और बहुत सारी तहकीक ने साबित किया कि अगर पार्शियल ऑब्स्ट्रक्शन 6 हफ्ते से ज़्यादा रहेगी तो किडनी डैमेज होना शुरू हो जाता है और नेफ्रोनल लॉस होता है, जो कि इरिवर्सिबल होता है। सो मैक्सिमम अगर वो मरीज जिसके के सिम्टम्स कंट्रोल्ड हैं, जिसको सेप्सिस नहीं है, कोई कॉम्प्लिकेशन नहीं है, उसको पेन उसका रिलीव है एडिक्वेटली, ऐसी सूरत में आप अप टू 6 वीक्स उसको अल्फा रिसेप्टर ब्लॉकर्स दे सकते हैं। अगर उसके बावजूद भी स्टोन पास नहीं होता या कोई कॉम्प्लिकेशन होती है या सिग्निफिकेंट पेन होता है, तो ऐसी सूरत में उसको आपको रेफर करना पड़ेगा।
थैंक यू सर।
यू वेलकम।
Any other questions from the participants? Any other questions from the participant?
Excuse me?
Sure.
Yes, my next question is that in a patient who presented with recurrent symptoms of BPH, so what do you suggest in such patient? Suppose if I started treatment to a patient and the symptoms relief, and patient stop medication after 2 months or 3 months, and then there is again recurrence of the same symptoms. In such a case, what do you suggest for such patient?
देखें, जो हमने आपकी सेकंड लास्ट स्लाइड थी, विच इज द relative indications for referral for these patient, or referral or relative indications for TURP or interventional treatment, उसमें यह है कि अगर आपके symptoms control नहीं हो रहे, दूसरी चीज ये है कि if your flow rate is poor under 10, if your symptoms are more than 20 on IPSS, तो ऐसी सूरत में you have to refer these patient for surgical management. So recurrent से आपकी मुराद है कि आपने एक दफा ट्रीट किया और वो बिल्कुल ठीक हो गए, आपने उनकी मेडिसिन बंद कर दी और फिर दोबारा से उनको सिम्टम्स हो गए। तो पहली चीज तो ये है कि जो मेडिकल ट्रीटमेंट है बीपीएच की, वो लॉन्ग टर्म ट्रीटमेंट होती है, उसको आपको सालों देना पड़ता है, उसको आपको कुछ अरसे 2-3 महीने दे के बंद नहीं कर सकते। सो इट इज लाइक हाइपरटेंशन, यू हैव टू कंटिन्यू ट्रीटिंग देम. It's very rare that you can take the medicine off and give them a drug holiday and see if they are doing well without medicine. But generally, these medicines have to be continued for long term.
Thank you.
You're welcome.
Any other question? All right. CCL is really grateful to all respected participant doctors, and special thanks to our worthy speaker, Professor Hamad Attar Saab, for sparing his time to deliver such an informative talk on LUTS. And we hope to continue such learning sessions in future as well, as we believe that there's still a lot of need to create awareness on LUTS. Thank you, everyone, and thank you, Hamad Saab, sir.
Thank you very much for the time, and I really enjoyed making this presentation and talking to these nice doctors. Thank you.
Thank you.